He will not participate.
We'll start, sir. It is 7:30 sharp.
Sure.
A very good evening to one and all. I heartily welcome all the members of API, ICP, and various other organization delegates who have joined for this API Karnataka Golden Jubilee webinar series. On this occasion of World Hypertension Month, May 2026 celebrations, I welcome our senior most guest of honor, Dr. P.S. Shankar, Professor Emeritus, RGHS Bangalore, and Distinguished Professor of Cable University. I welcome our today's chief guest, Dr. G. Narsimlu, President National API from Hyderabad, a senior rheumatologist of the country, a great academician, researcher, a teacher par excellence, with many publications both at national and international levels. A dynamic personality in API has taken API to a great heights. I welcome our other guest of honor, Dr. Girish Mathur, Dean Indian College of Physicians from Kota, a great academician, past president of API, dedicated to API, a great name in the field of API in the country, loved by one and all. I also welcome our other guest of honor, Dr. A. Muruganathan, Director PRF, past Dean and President API, former Governor ACP India chapter, who has received many awards and fellowships, a dynamic personality in the field of medicine in the country. Welcome our today's dynamic speaker, Professor P.C. Manoria, Chief Cardiologist from Bhopal, past President of CSI API India, a great academician, teacher of teachers. He never said no to any of our earlier invite that speaks about his dedication to teaching and training the young physicians. I welcome our today's moderator, Professor Dr. Nagaraj Desai, cardiologist from Bangalore, a great teacher and academician as well. Welcome our today's panelist, Professor Dr. G.S. Wander, cardiologist from Ludhiana, the past president of API, past director PRF API, a great academician, researcher with many publications at national and international levels. He is a teacher par excellence, now heading the Dayanand Medical College, Ludhiana, a great name in the country in the field of cardiology as well. Welcome our own faculty, retired Professor Dr. Jayant Tantani, senior most cardiologist from Pune, the earlier faculty of our own Gulbarga MR Medical College. I also welcome our other panelist, Dr. Ashok Kriplani, Chief Nephrologist from Mumbai, dedicated to nephrology with many publications and awards to his credit. I welcome our own organizing team headed by Dr. B. Ramesh, Chairman API Karnataka, Dr. Ravi Kirti, Vice President National API, and Chairman-elect API Karnataka, Dr. Srinivas Murthy, National API member, Dr. Suresh Sagrath, past Chairman API Karnataka and Faculty Council member, National API, Dr. Mohan Kumar, Secretary API Karnataka. I welcome all delegates who have joined from all over the country, making a national event, which COVID-19 has taught a new normal life. Let us not waste time by reading their CV profile. Let us hear and learn from them. Lastly, I welcome one and all. Now we have a formal virtual inauguration.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
We are virtually honoring all the faculty as well. Now I request Dr. P.S. Shankar for your introductory remarks, sir. Dr. P.S. Shankar, sir, for your introductory remarks. Kindly unmuted.
Dear colleagues, we have assembled to celebrate the World Hypertension Day, a day designated and initiated by the World Hypertension League, which is itself an umbrella to organization of 85 national hypertension societies and leagues, including India. The day was initiated to increase the awareness of hypertension. The World Hypertension Day 2026, the theme is controlling hypertension together. Check our blood pressure regularly. Defeat the silent killer. This theme emphasizes the importance of regular monitoring to know your numbers as hypertension rarely displays visible symptoms. And this theme emphasizes the importance of regular and accurate blood pressure measurement for early detection and control of hypertension, which is crucial for reducing the risk of the serious health complications like heart disease, stroke, and the kidney failure and early death. And it aims to raise global awareness about the high blood pressure, promote prevention, detection, and control, and encourage action at individual, community, and health system levels. Hypertension remains the leading preventable cause of premature death worldwide. An estimated 1.4 billion people live with hypertension globally. Despite the availability of effective and affordable treatments, many people are unaware of their condition, and only about 1 in 4 people with hypertension have their blood pressure adequately controlled. Early detection, regular monitoring, and a sustained treatment can prevent most hypertension related complications. The objective of World Health Day, Hypertension Day, is to communicate to the public the importance of hypertension and its serious medical complications and provide information on prevention, detection, and treatment. The World Hypertension League launched its first World Hypertension Day on May 14, 2005. Since 2006, the day itself has been dedicated May 17th of every year. The regular blood pressure measurement is the first step to prevention and control. Everyone should know their blood pressure values. Hypertension can be prevented and controlled by healthy diets, physical activity, avoidance of tobacco, reducing alcohol intake, and appropriate medication can significantly reduce the risk. Early detection saves lives as most people with hypertension are unaware they have it. Screening and routine measurement are essential. Affordable, effective treatments are widely available and can prevent serious complications when taken consistently. Hypertension management is lifelong and depends on sustained access to care, medicines, and follow. The objective of the day is to promote higher level of awareness of high blood pressure with accurate measurement of the blood pressure, aiming to control non-communicable disease caused by the hypertension. I am happy to see Dr. Manoria, Dr. Antani, Nagraj Desai, and Gumdal Narsimulu who are taking part in this program. I wish the program all success. Thank you.
Thank you, sir. Thank you for your kind words. Now I request Dr. A. Muruganathan, sir, for your kind words of wisdom.
Good evening, everyone. Dr. Sangram always organizes program according to the situation. So I thought he will do a program on May 17th. So he missed it. So he's compensating it doing this. I also wanted every one of my friends to send the readings for press study. So hypertension, not only we have to talk about the theory and then awareness, we must also do something in India, because hypertension registry is not there, and we must also do something on home blood pressure monitoring. So these are the areas I am interested. So I want the faculty and the audience to think about these things and then start doing some research, some registry, some work on hypertension, and also promote home blood pressure monitoring. With this, I thank all of you, and I can see my friend P.C. Manoria, Sangar sir, then Wander, Kripalni, and other people here. Thank you so much. Over to you, Sangara.
Thank you, sir. Thank you. Now I request our Dean, Dr. Girish Mathur, sir, for your address.
Thank you, sir, Dr. Sangram. Good evening, friends. Honorable Dr. Narsimulu, President API, Muruganathan, Director PRF, Manoria, Dr. Sangram Biradar, and all participants. I extend my warm greetings on behalf of Indian College of Physicians. It's very heartening to note that on the occasion of World Hypertension Month, API and ICP Karnataka are organizing an academic webinar on a highly contemporary and evolving topic, gene therapy and novel drugs in the management of hypertension. Hypertension continues to remain one of the most important contributors to cardiovascular and renal morbidity worldwide. With rapid advances in medicine, newer therapeutic approaches, including gene-based interventions and innovative pharmacological agents, are opening exciting possibilities in the management of resistant and complex hypertension. We are privileged to have the eminent cardiologist, Dr. Prabhash Manoria, as a speaker for this academic session. His vast clinical experience and academic insights will certainly enrich our understanding of future directions in hypertension management. I welcome moderator Dr. Nagaraj Desai and an outstanding panel of experts comprising of Dr. G.S. Wander, past President API, a distinguished cardiologist, Dr. Jayant Antani, eminent cardiologist, and Dr. Ashok Kriplani, renowned nephrologist, whose valuable perspectives will add depth and clinical relevance to the discussion. I'm confident this webinar will provide an excellent platform for learning, interaction, and exchange of ideas among physicians and healthcare professionals. My best wishes for the success of today's event. Thank you. Over to Dr. Sangram.
Thank you, sir. Thank you for your kind words of wisdom and sparing your valuable time. Now I request our President National API, Dr. Narsimlu, sir, for your inaugural address. Unmute, sir. Kindly unmute and speak.
Now, thank you, Dr. Sangram Biradar. Dr. Sangram Biradar is excellent academician and a hardcore worker of API for his membership drive and various academic API. Thank you, Sangram, a lot on as a API president. My other colleague, Dr. Ramesh, Chairman of Karnataka API, Dr. Mohan Kumar, Secretary, Ravi Kirti, Vice President API, Srinivas Murthy, Governing Body Member, and Suresh Suresh Sagar from Raichur, a great academician and done a lot of membership drive. And my mentor, my teacher, and former Governing Body Member also, Dr. P.S. Shankar, because of whose blessings I am today. And Dr. Jayant Antani, he also my teacher, my mentor. And my former president and dean and presently director PRF, Dr. Muganathan, my friend dean, Dr. Kirish Mathur, very efficient, highly forethought planning of the API and API responsibilities. And Dr. Manoria, my old friend and past president and good cardiologist. Dr. Nagaraj Desai, he was my 2 years senior to me. We stayed in the same building in Gulbarga. We studied together a lot. And my friend Dr. G.S. Wander and Jayant Tantani, my teacher, and Ashok Kriplani, a renowned nephrologist from Mumbai. May all colleagues who are participating in this event. Let me tell, API celebrating May month as hypertension month. We have started recording BP of all patient attenders. We are aiming on people who never detected BP in schools, colleges, colleagues, hospitals, institutes, and in the hospital patient attenders, and giving very fruitful results. Till now, we have conducted nearly more than 80 to 90 programs. The Sangram significantly contributed in this field, and also the Suresh also contributed, and the Ravi Kirti also contributed. Karnataka, Telangana also we have done a lot number of programs. Programs are happening from Kashmir to Kanyakumari, and very happy all our API members contributing for API activity. And also request anybody in the event who are participating in this academic, who are not API member, kindly become API member. Now for next 2 to 3 months, we are given a discount of membership of 10,000 rupees. And contribute for API by involving organizationally, academically, and make health for all within their affordability. And more than that, theme of my last conference, best medical service with humanitarian touch rather than commercial touch. And these programs will definitely touch the ideology of our API. And let me tell about hypertension. When I was a student, there were very few drugs. The treatment is step 1, step 2, step 3, step 4. Vasodilators is lost. Now the no more. In those days only, the Chaintantani worked on vasodilators, helpful in hypertension, congestive cardiac failure, where even textbooks also never mentioned. So I had a opportunity to work under a great teacher like P.S. Shankar, Jaintantani, and late Dr. Muralidhar Rao, whose teaching, whose ideology is still helping me, and their blessings and my patient blessing, my student blessing, which has made me to reach the stage what I am today. I was the dean, former dean, I was the president, I was the president of ISCM, I was the president of IRA. Everywhere I could contribute with these people's blessings. And lastly, I wish Sangram continue to work like this and contribute to API. It will a lot of future for you in API. I wish the program grand success, and hypertension one day we'll see that nobody on the earth should not be knowing that what is BP. At least every their birthday they should check their height, weight, and BP. Now I started checking BP of all people, attenders who are coming to my clinic, and I could detect nearly 10 to 12 in last 1 month. They have BP, but they don't know. So a lot of people who have hypertension, they're not getting detected. We need to concentrate this whole month for this. I wish this meeting grand success. Over to you, Dr. Sangram.
Thank you, sir. Thank you for your words of wisdom and sparing your valuable time. Now we move on to the scientific session. I request Dr. Nagaraj Desai sir to take over further, as already faculty have been introduced. Over to you, sir. Unmute. Unmute.
Respected faculty and the respected gathering on the Zoom platform today. The hypertension is such a vast topic. The universe is so large, it is impossible to kind of pick a topic which is important and which is cutting edge. Sangram, along with his colleagues, has decided to discuss with us the cutting edge topic like, modern drugs or newer drugs for hypertension, and also the genetic therapy for hypertension. It has relevance, no doubt about it. I'm sure when my good friend and senior Dr. Manoria discusses this topic, he will keep in mind that what should be done for us to incorporate these newer thoughts into our clinical practice. Just to give you a kind of a initiator, just about a few weeks ago, or a couple of months ago, there was an article from Telangana, that is Dr. Narasimha's hometown, selecting a drug therapy for hypertension based on the genetics. And they described, they kind of observed that the patients who were receiving the genetic-based responses, they did better when compared to the control arm, suggesting that there is a kind of so much to learn as to when we prescribe medicines for hypertension, whether these drugs are going to respond, or these patients are going to respond or not. More about to learn what is happening in the world and universe of hypertension. May I request now Dr. Manoria to get started, and let's listen to the legend in the area of cardiovascular medicine. Dr. Manoria, please.
Yes, sir. Slides are seen.
So for the next 15 minutes or so, I'll be talking on dawn of a new era in hypertension management, novel drugs, and the current status of gene therapy. So when we look at the next generation antihypertensives, what do we know? We have a aprocitentan, a dual endothelin receptor agonist, which has already been approved by FDA in 2024 and will be available in India in times to come. We have Bacrostat, which is approved in this month by US FDA for treatment of hypertension, and I'm sure AstraZeneca will be bringing this molecule in times to come. And this is zilebesiran, which is a small interfering RNA. A single injection lowers blood pressure for the next 6 months. GLP-based therapies for obesity, which is reaching alarming and epidemic proportion. I'll show you some data. And these APA inhibitors and natriuretic peptide agonists, they are in the early phase, so I'll not be discussing them. In hypertension, the biggest problem is compliance. Compliance is very, very difficult for any individual to take drugs for 5 years, 10 years, many decades, rather lifelong. But now gene therapy may come to our rescue in times to come. And we are amidst a dawn of a new era in hypertension management with gene therapy. And there are 3 types of gene therapy which are being evaluated. One is the small interfering RNA, that is zilebesiran, which is already evaluated in a phase 1-2 trial, and the CV outcome trial is ongoing. I will show you the data, and this works on the principle of RNA interference. Antisense technology, which we call it ASO, which is a single strand DNA is this molecule, which is being evaluated. I'll show you the data. And the most novel technology is gene editing with CRISPR-Cas9, one-time treatment for the rest of life. And this is also being evaluated for targeting angiotensinogen, so a single one-time infusion for the rest of the life. In times to come, drug treatment for hypertension will be able to take a vacation with this molecule. So let's see how this works by targeting angiotensinogen. Now, zilebesiran targets angiotensinogen. It decreases the production of angiotensinogen, and therefore there's decreased RAS activity. And this has already been evaluated as phase 1, phase 2, Cardia 1, Cardia 2, 3 trial, and the CV outcome trial is already kicked off and is ongoing. When we look at this Cardia 3 trial, you can see a single injection at the end of 6 months decreases blood pressure by 15.6 millimeter, which is 7.4 more than the placebo on top of the other antihypertensive drugs. And this is ambulatory blood pressure monitoring. Again, you can see substantial reduction in the blood pressure, whether you're talking of daytime or nighttime blood pressure. And if you are on a diuretic, as you can see here, the blood pressure reduction, systolic blood pressure reduction is to the tune of 21 millimeters mercury, which is 9.2 more than the placebo group. So significant reduction with this molecule. The CV outcome phase 3 trial is ongoing, and we are keenly awaiting the result, whether zilebesiran will improve the CV outcome of patients of hypertension. You can see the primary outcome is CV death, non-fatal MI, non-fatal stroke, or NHF event. Now, tolmesan is an antisense technology, which again targets the angiotensinogen. And you can see the Cardinal trial is ongoing with this technology to see how it works. And this is the most novel technology, CRISPR-Cas9 technology. It has 2 components, a guiding RNA, which locates the specific genomic focus, and the Cas9, which produces a double-stranded break in the gene, and when this gene heals, it loses its function. So you'll see the Cas9, the guiding RNA has located the angiotensinogen gene, and the Cas9 has produced a double-stranded break in this gene. And when this gene heals, it loses its function, and this patient becomes a case of loss of function of angiotensinogen, and the RAS activity is decreased to the rest of his life. So very, very interesting. This technology is already approved for sickle cell anemia, is already undergoing trials in New Zealand for PCSK9, and so again, the future is that this angiotensinogen may be targeted by this CRISPR-Cas9 technology. The second issue is why there is a necessity for newer and newer molecules for treatment of hypertension. Time and again, see another new molecule comes, another new molecule. Why this necessity? Now, there are several reasons for this. One of the reasons is even we treat hypertension by the guideline-directed therapy, which means we use dual therapy, we use triple therapy, we take all precaution to exclude the secondary cause, compliance issue. Still, the blood pressure is not controlled. We label it as resistant hypertension. Add an MRA, still not controlled. We add all these drugs, alpha blockers, and so on, beta blockers, still not controlled. So this also seen in substantial number of cases. The second reason is that the targets for BP control across the globes are being slashed down. So whatever is the guideline, whether it is ISH or whether ESC or American Heart Association or American Diabetes Association, the targets are less than 130 by 80. And with the available drugs, it may not always be possible to lower the blood pressure to this target without any side effects. So there's always a necessity of effective and a less toxic drug. The other reason is it is seen, as you can see in these trials, that if you have a tight blood pressure control less than 130 or even 120, dementia and cognitive decline are much less. So one of the other reasons for treating hypertension besides decreasing stroke, MIHF and CKD is dementia. Very, very important reason. And you can see is a class 1A recommendation by ACC, AHA guidelines. Now, so what are these new drugs? One of the drug is aprocitentan, which was approved after the precision trial in 2022. And as you can see, is a dual endothelin antagonist, ETA and ETB. Endothelin is the most powerful vasoconstrictor. Endothelin ETA decreases vascular tone. ETB blocking produces decrease in the muscle hypertrophy. And this is the reason why it is very effective in the treatment of hypertension. This was approved by after the precision trial. The trial is little complex, so I'm not going into the complexity of trial, but you can see substantial reduction in blood pressure. Ambulatory blood pressure also, you can see substantial reduction. And this again, reduction in systolic blood pressure. You can see again significant, and also daytime and nighttime on ambulatory blood pressure. The second group of drugs are aldosterone synthase inhibitors. These drugs specifically block the CYP11B1, which blocks the synthesis of aldosterone, doesn't affect the cortisol synthesis. And there are several advantages of aldosterone synthesis inhibitors, unlike mineralocorticoid, conventional mineralocorticoid blockers. Counter-regulatory increase in the aldosterone with MRAs does not occur with aldosterone synthesis because it is blocking the synthesis. ASI spare the glucocorticoid-mediated activation of the MR. MR blocking is not specific. Off-target estrogenic side effects of some of the MRA do not occur with ASI, and the non-genomic effects of aldosterone may not be inhibited by all MRAs, but may be inhibited by aldosterone synthesis, which means the inflammation and the oxidative stress. As you can see, Bactrostat is the most widely evaluated molecule and is approved by US FDA only on 18th May 2026 for treatment of resistant or uncontrolled hypertension. Dextrostat is being evaluated for aldosterone, Victrostat for HF and kidney disease, and lorundrostat for HDF, kidney disease and OSA. All these three molecules are not in late stages, they're in early stages, but Vectrostat is the most widely evaluated now approved for clinical use by AstraZeneca, is the company which will be bringing this molecule to India. This was the preliminary phase 2 trial, BRIG-HTN trial, and you can see 1 milligram lowers systolic blood pressure was 17.5 millimeters. 2 milligram by 20, you can imagine the potency of the drug. Hardly any side effects except some hyperkalemia. And look at the diastolic blood pressure, 1 milligram, 11.8, 2 milligram, 14.3. This is a phase 2 trial, and the change in the systolic blood pressure over time, again, you can see significant reduction. Now, this is the PAX-HTN phase 3 trial, after which it was approved by US FDA. 794 patients, and all these patients, the blood pressure was difficult to control. So, uncontrolled hypertension, which means a CT systolic blood pressure between 140 and 170 millimeter, despite treatment with maximally tolerated 2 antihypertensive, or resistant hypertension, which means CT systolic blood pressure 140 and 170, and despite treatment with maximally tolerated 3 or more antihypertensive, 73% were resistant, majority were resistant hypertension. And you can see 1 milligram decreased blood pressure by 8.7 on top of the other drugs, and 2 milligram by 9.8, which is quite significant. Hyperkalemia occurs in small number of patients, otherwise well tolerated. And this is the PAX-24 ambulatory blood pressure trial, again a phase 3, and you can see significant reduction in blood pressure with Vectrostat. You can see 14 millimeter in the 24-hour ambulatory systolic blood pressure in patients with resistant hypertension. Lorundrostat is in the preliminary stage and is showing data just like Vectrostat, so I'm not going to discuss much. Then we have the incretin-based therapies. All of us know hypertension in patients with obesity is a common problem and occurs due to a panoply of mechanisms, which you can see on the screen. So those patients who are obese, hypertension is rather inevitable in the long run. And these are some of the effects of anti-obesity. They decrease blood pressure. But the very exciting data emerged from the SURMOUNT-1 trial. You can see the baseline systolic blood pressure is 123. This is tirzepatide, 5, 10, 15. And you can see, despite the blood pressure being near normal, 123, the blood pressure is decreased by 8.2 with 15 milligrams, 7.6 with 10 milligram tirzepatide, and 7 with 5. So tremendous reduction. So one of the other uses of this molecule would be to decrease blood pressure. You can see when it is in the normal range, if it is hypertensive range, the things would have been different. And again, for the diastolic, look at the diastolic blood pressure was 79.5. Just the target, still it reduced blood pressure by 5.5 in a dose of 15 milligram. So very good anti-hypertensive effect was demonstrated in SURMOUNT-1 trial. It has a sub-study of the ambulatory blood pressure also, and you can see again substantial reduction in blood pressure, and the benefit was seen across all subgroups. And this is a anti-obesity medication, a 2BB recommendation, just like bariatric surgery for treatment of hypertension by the guidelines. The other molecule which I am going to discuss is ARNI. All of us are using it for the treatment of heart failure, I think day in and day out, and it is very dramatic result. But now ARNI is also being evaluated for hypertension. It's already approved for treatment of hypertension in China and Japan. And you can see what are the various potential multiple mechanisms by which ARNI control 24-hour blood pressure. You can see diuresis, decreases salt sensitivity, decreases renin secretion, decreases arterial stiffness, decreases sympathetic outflow, decreases CV fibrosis, decreases vasoconstriction, left ventricular. So there are multiple mechanisms, and in our personal experience, the results are very dramatic. Blood pressure not controlled by any combinations. You add ARNI, it gets controlled, and that's what the data is shown by several other trials. Now, this is a data which you can see effect of ARNI versus the patients who are on other drugs, say other RAS blockers, and usually when this ARB was replaced by ARNI, you can see the blood pressure less than 130 goal was achieved in 80% of the patients. You can imagine the potency. Patients who are on multiple drugs, one of the ARB, replace ARB with ARNI, and 80% the patients were to achieve the goal of less than 130. Side effects were not increased because we wanted to see if the drug is efficacious. Does it increase side effects? Side effects were not increased. Now, this is another data from Japan, which was published in 21. You can see again significant reduction in systolic pressure, diastolic blood pressure, and mean pressure. And this is another data again, I think, from Japan. You can see sacubitril valsartan, 200 milligram, 100 milligram twice daily, 200 milligram twice daily, and olmesartan. Olmesartan, we used to say it will double-digit reduction in blood pressure, but look at this. With 218 millimeters with 420, diastolic again 8.79, and mean pressure also similar. So ARNI has a very potent antihypertensive effect. Another data from ambulatory systolic blood pressure, you can see again the yellow one is sacubitril 200 milligram per day, 13 millimeter with 400 milligram, it is 15 milligram. And this is compared to olmesartan itself is a potent drug, whether it is daytime systolic blood pressure or nighttime. So again, very, very good. And this molecule is already approved in China, I think, a few years back, and also in Japan now. And very likely, I think, would be approved in other countries too. But don't forget, whatever treatment you're offering to the patient, the basics still matter. So don't forget all these basics when you are treating a patient of hypertension. Thank you very much for your kind.
Kindly unmute, sir, Nagaraj.
Yeah. Thank you, Dr. Manoria, for that wonderful and very thought-provoking presentation as to how one should be kind of aware of when the patient comes with difficult to treat hypertension while taking care of the non-pharmacological issues, but also consider the newer therapies that are being available. And it is indeed possible that quite a few of us would have participated in this Baxdrostat trial, which of which many of us were part of this particular trial. I find that Dr. Wander is there in the faculty and also many others. I'm sure. Let's hear from them what they have got to say. Dr. Wander, please, you have any thoughts about the thoughts on the topic?
So Dr. Wander is held up. He'll be joining shortly. He told
Okay.
he'll be joining shortly.
Oh, okay. And the other faculty that they are there as the panelists, please, Dr. Nephrology colleague, and what he thinks about the resistant hypertension and the contribution by the kidney. As they
Thank you, sir. Yeah.
Go ahead.
Sorry, go ahead. Sir.
Go ahead, sir. Go ahead, please.
Thank you, sir, for having me, and thank you, Dr. Brother and Dr. Manoria. Dr. Manoria, that was very exhaustive for things to come, very bright. But I think that, of course, we all, especially we nephrologists, are looking for resistant hypertension. The unfortunate fact is that most resistant hypertension is not resistant. So I think that we have to emphasize that one, the education of hypertension is not enough. We have to push forward in the medical colleges a lot of education respect of hypertension. Not much, as I see in the curriculum, is being devoted by cardiology or nephrology to teaching the undergraduate. And that is where the problem lies. When we say resistant, you know that half the time when people are referred to a specialist for resistant hypertension, it turns out to be non-resistant, but resistant doctor, resistant patient, but not resistant drugs. And so the hypertension education and this once in the year, May month of Know Your Numbers is an excellent idea. Just like the diabetologists have got involved in education for diabetes, we should also push for that. And I think it's very important that some of us become hypertension specialists and start imparting education in the medical colleges to the students. So that's where the primary fault will lie. The diabetologists have done it well. I think they have beaten us to it, and we should be doing that. That's my first point. Of course, the new drugs are miracle drugs. but some of them, they compromise one organ for the other. For example, if you start using ARNI as an antihypertensive agent, most of my patients will leave me and say, go to hell, because the creatinine invariably goes up. The potassium may not be such a problem because there is also a diuretic involved. The natriuretic peptide will take care of the potassium to some extent. But the fall of GFR and creatinine rise in almost all these new drugs. It's difficult for us as nephrologists. A patient comes to me with resistant hypertension in CKD to tell him, look, creatinine used to be 1.6, now it is 2.2, but that's okay. Very difficult to accept that. In fact, I was asked to do the trial of ARNI much before, about 6 years ago, by the company, and I refused because I said, how will I face the patient? And we have to get ready to face the patient. Dr. Manoria knows that in all my lectures, I say kidney ko goli maro. Don't worry about kidney. You can live without 2 kidneys, but you can't live without a heart. And that is my principle. But how to convince the patient? How many patients I must have lost trying to reach target of 120? It is glibly said, reach 120. But when the patient comes back, he is upset, he is not happy, because there's nothing cogent that he can grasp on to prove except the proteinuria. There, of course, I convince him that, look, the proteinuria has gone down. That's the thing that is troubling your tubules and your heart. And even that, many people say, oh, that's in the kidney. So what has proteinuria got to do with ASVCD? Then I have to explain that to him, that the same cytokines are there in all vessels, and therefore the leakages are taking place in all vessels. But it's difficult. So the education program, again, educating the educators, educating the undergraduates, even educating our other colleagues. We have to accept the homeopaths and the Ayurveds as colleagues now. The government won't let us live peacefully otherwise. So better to teach them. Dr. Manoria, what do you think?
Sir, you get the most difficult to treat kidney invariably compromised. So your experience is like that. You get the most difficult, resistant, other super resistant, or whatever you say.
Actually, in fact, I am also one of the advocates of involving ourselves in the undergraduate education in a very effective manner. And NCDs are not kind of attended to by many of the departments of medicine, and NMCs will take care of it and address this issue on an urgent basis. Now, having said that, I want to come back to the topic of hypertension and also the topic that is being discussed by Dr. Manoria. You find that most of the trials of the newer drugs, they always had a diuretic on board. And importantly, having no diuretic on board, it should not be a resistant hypertension, as was mentioned by our nephrology senior, was also that the worsening of the renal function is an important clinical issue. And third important thing is, many of these modern trials are being recruiting the patients with the unobserved blood pressure, like the sprint blood pressure kind of a measurement, suggesting that our approach should be that encouraging the blood pressure being evaluated outside the physician office, and also outside the office of the patient, of the physician himself, like ambulatory blood pressure or like a home blood pressure monitoring to manage the blood pressure, so that we offer appropriate management. What do you say about this, Dr. Manoria?
It is true that the time given for teaching hypertension is very less. In undergraduate, even in postgraduate, hypertension is virtually a neglected topic. No postgraduate bothers about. He bothers about cardiac arrhythmias. He bothers about other acute myocardial infarction, other emergencies, pulmonary embolism, and acute kidney injury. But the time which is the leading cause of cardiovascular morbidity and mortality, the time given for teaching hypertension is very less. That is very true.
Yeah, there should be some kind of a modular kind of rather education over and above what is being taught on a kind of on a Zoom-based education. The API can take lead with so many varieties of forum they have, they should be able to take a lead to have some kind of a 5 modules or 5 lecture based module of hypertension and other issues. I'm digressing again, but to come back to this topic of genetics, do you think, Dr. Manoria, in the foreseeable time, we will be evaluating the genetics of the patient to kind of a selected drug? What is your hunch?
See, pharmacogenomics has definitely a place. Some people respond to a particular in a better way than so. Pharmacogenomics is very, very important and is fruitful, but the facilities are not available. Pharmacogenomics, we know it for so many years, but in India, I think the facilities are available very limited.
Okay.
Some will respond to RAS, some may not respond to RAS blockers. Yes.
The
Sir, may I make a comment?
Sorry.
May I make a comment?
Kindly, sir.
I'm worried, Dr. Manoria, that if I completely block the angiotensinogen for 6 months and the man gets a severe diarrhea and vomiting, I will have compromised nature's own system that protects the patient from death. The RAS system is devised by nature to protect me from such situations. So such compromise is extremely risky, in my opinion. Even I have patients on olmesartan. First thing I tell them, you get diarrhea, stop this drug. If he's getting for angio or he's going for major surgery, gallbladder or something like that, I tell them sick day, not allowed. But this will permanently block it for 6 months. There is no antidote to it. This is my worry, my anxiety. Dr. Manoria,
you are very
thoughts?
right. This issue has been discussed, and now before this drug comes into market, they are already developing an antidote. You are very right. Otherwise, somebody goes in shock, he will not recover. So antidote will come before the drug. So both will come simultaneously. The event, as you are pointing, which is not somebody gets a myocardial infarction, somebody gets serious gastroenteritis, or somebody gets a trauma and goes into shock, it will be difficult to, because you have blocked the RAS.
Yeah.
You are very right. So this is being discussed by the trialists also. They are getting an antidote first before blocking the RAS for next 6 months. Very true.
Yes. Actually, in fact, many my cardiac surgeon stops the RAS system blockers before the surgery, because he says that post-operatively, peroperatively, a system can develop like a vasopregia, which is non-responsive to routine drug therapy, suggesting that one should be careful about the total blockade forever,
blockage,
and for a longer time, the RAS blockade at least. So, I mean, what is your take on patients who have hypertension and who have a mild renal dysfunction? And what are the deaths of mild renal dysfunction? Let both of you can answer as a cardiologist and as a nephrology colleague. And what do you want to kind of, match and, combine the drugs?
If you have a proteinuria going, your UACR is more, the first drug of choice has to be RAS blocker. And then you can add on the other drugs, calcium channel blocker or diuretic. But the first drug, because it decreases proteinuria, which slows down the progression of CKD. So RAS blocker has, Dr. Kiplani gets very, very serious cases, highly compromised. So we'd like to have his opinion. What does he do? Because already creatinine is 2.4 or more. How does he use RAS blockers?
Thank you, sir. I'll respond to 3 points. One is recognition of renal dysfunction, which often is missed by the non-nephrologist, because the range of creatinine from 0.8 to 1.2 is very, very fallacious. And when we lose 50% of renal dysfunction and the lab report shows that creatinine is normal. But now more and more people are using EGFR. And in fact, sometimes we find that too many people are coming with pseudo-renal failure because they get worried when the GFR is 76. Now, above 60, one should not accept GFR unless there are other markers like proteinuria, red cells. Otherwise, 60 is the point at which alarm bells should ring. Of course, if there is diabetes, there is the other concomitant comorbidities, then one has to accept those. But on its own, EGFR is also carrying some fallacies. The other point that I want to make is that we are more now able to use RAS blockers to the maximum because of the potassium sparing the powders, that the Lokelma and the Patiromer, we are able to push these drugs to the maximum. A lot of my patients whom I used to withdraw and then get very sorry that I withdrew, because there is a study which called Stop ACE, in which we stop ACE inhibitor and the patient's rate of progression of renal failure rapidly increases and proteinuria returns with a vengeance if I have stopped because of potassium of 5.8. So now instead of stopping, we cut down for a couple of days, restart with either, now Lokelma is freely available, although it's very expensive. The poor man's Lokelma sometimes I have to use is the aldosterone substitutes, which give, if the potassium is running at 5.9 because of RTA type 4A, which is a hyporeninemic hypoaldosteronism in a diabetic, then if I can't afford the drug Patiromer, or if I can't afford Lokelma, then I have to come back and use one of the steroids, which will be protective of the potassium. So that's a poor man's way of handling it. But we don't now stop ACE inhibitors and ARBs when we have this in the armamentarium. So if the patient can afford it, we are able to push it in from the, and particularly, sir, for us, heart is king. If I protect the heart, the patient will come to me for transplant. If I let him die from HFpEF, which is microvascular rather than macrovascular MI, which is coming more into prominence now. The microvascular the part of cardiac disease from hypertension and cardiac failure is becoming more and more. I find more of my patients not on nitrates, but on the other drugs like Nicorandil, etc., because they are recognizing many patients with angina which are not NODAC, non-obstructive non-obstructive coronary artery disease. So it's now a widening spectrum amongst cardiologists, not only looking at doing angiographies and opening up the large arteries, but also protecting the heart with these ACE inhibitors, ARBs, and MRAs. And of course, the SGLT2.
Thank you. Thank you so much. In fact,
Dr. Antani, Nagaraj, this is sir. Antani sir is also there. You can have his.
Yeah, in fact, I was about to request Dr. Antani, professor, to make his comments and what he has got to say about the newer
I
molecules.
think I am learning a lot from Dr. Kriplani. It has been a wonderful exchange of thoughts and correct scientific information regarding the treatment, particularly with the kidney. And we often ignore kidney for a little late. We come into picture a little late, we get nephrologist on job. I think that is the first thing that I think UCAR and must be done, EGFR must be done very early, so that we can interject. My question, another question to Dr. Manoria is that LVH with mild renal dysfunction, how do you manage? LVH we see very often now with the controlled hypertension. LVH we see often on controlled hypertension and diastolic dysfunction. So how do you manage?
If you are talking of renal dysfunction, if the UACR is abnormal, either micro or macro within more than 30 or more less than 30 to 300 or more than 300, again RAS blockers would be the first of choice. Regression of LVH again is best with RAS blockers. So we will be using RAS blockers, if necessary, add-on drugs.
Yeah. In fact, most of the drugs used for hypertension reduce left ventricular hypertrophy, except possibly, drugs like diuretics and calcium entry blockers, especially the nifedipine, which we hardly use nowadays. But suffice to say here that, RAS blockers carry the flag for the management of hypertension. Thank you, sir.
Now what is the current role of phaneron or epleron in hypertension when we manage?
Dr. Manoria, would you like to add this?
See, phaneron is used by the nephrologist, also cardiologist, is a drug which is approved for mildly reduced ejection fraction and for HFpEF, and it slows down the progression of CKD. So if you are already on a RAS blocker, you are also on an SGLT2 blocker, this is the third drug which can be used. And of course,
I would li-
hyperkalemia is a problem which you should always monitor.
Uh,
And combination therapy has also been shown to produce superior results rather than one. And all these drugs provide incremental benefit on top of. So they produce incremental benefit. And now the semaglutide injectable is also approved because the trial shows positive results, the flow trial. So these are 4 drugs which are used to slow down the progression of CKD.
I would like to hear
Kripalani
from
will be
Dr.
able to tell you.
Kriplani. I would like to hear from Dr. Kriplani regarding Fineron.
Sir, Fineron is so far not a very powerful antihypertensive. It is
Right.
more antiproteinuric, particularly in the diabetic. And
Right.
it is the third drug in the armamentarium. It would first be SARB, second MRA if tolerated, and of course SGLT2. And then, having got that, they aim to get more proteinuria out. But it's newer variant. I think it is called Esperanson or something like that, which is about to come in Indian market, is more powerful as antihypertensive. Although it is the same group of non-steroidal MRA, it is more powerful antihypertensive. So that drug will probably be useful for the hypertension, the resistant hypertension. But again, the Fineron has potential to give hyperkalemia. So one has to keep a watch, although not as powerful as the spironolactone and eplerenone, but it is more useful for us for proteinuria. When the new drug comes, it will be probably better off with the
Thank you, sir.
Yeah.
And in fact, as we are logging into the last minute of the discussion, I find that, when there was liberalization of the MRA into the practice with the good data, Canadian observational studies published saying that hyperkalemia was one of the most common ER visits that they encountered, saying that, as was Professor Kripalani was also mentioning, that one should be careful when we use the drugs. And potassium is a bugbear of clinical practice of modern cardiovascular and renal practices. And when we manage our patients of hypertension, make sure that the blood pressure is measured appropriately, and make sure that the patients are compliant to the medications and in combinations, and make sure that the patients are following up with you so that all the non-pharmacological issues are also kind of adhered to. Do you have any parting comment, Dr. Manoria, on this particular presentation of yours, which is so beautiful? Thank you.
I think one of the things which I'd like to say is we are chasing blood sugar, we are chasing LDL cholesterol. We must also chase UACR, because by the time the patient these days referred to nephrology,
Correct.
GFR is already, UACR is already high,
Very correct.
GFR is 30 or 25, nothing can be done. We have very
Very
excellent
correct.
drugs which slow down the progression of proteinuric nephropathy. So I think this should be added in our armamentarium. Chase UACR also, particularly if the patient is diabetic, maybe once in a year or more, depending on the subset, hypertensive also. All causes of CKD, UACR must be changed, because we have very good drugs which slow down proteinuria and
Very
postpone
correct.
dialysis by 10 to 15 years. So
Very correct.
UACR must be a new target for the cardiologists. Nephrologists, of course, they always use, but cardiologists I've seen hardly use UACR.
Yeah, hardly use. Yeah.
Perfectly.
Very correct.
Thank you, sirs. And in fact, we had a wonderful discussion, wonderful presentation. Thanks to Professor Manoria, Professor Kripalani, sir, Professor Antani, and all the panel. And I hand over the mic to our chief organizer, Dr. Biradar, please.
Yeah, it was a wonderful moderation, sir, and all the speakers have done a great job. Before we conclude, let us have a single one-word comment for takeaway from the speaker. Dr. Kripalani, sir, your comment, one word, key takeaway.
Key takeaway, sir, we need more education for hypertension. And we have been beaten by the diabetologist. It's time that we beat the endocrinologists and the diabetologists, because there is more death from hypertension than there is from diabetes. That's my key comment, sir.
Thank you, sir. Manoria, sir.
Your numbers of blood pressure should be made compulsory and bring them to the targets. Knowing numbers of blood pressure is very important for everyone. It should be made compulsory.
Yes, sir. Antani, sir, your comment, your one word.
I think kidney must be kept in mind from the very beginning.
Okay. Yeah. Nagaraj Desai, sir.
In fact, I enjoyed the whole session. I don't know how to say it in one word. In fact, be inquisitive, be interested. Hypertension is a silent killer. It will not go away from your kind of world, and clinical practice will be exciting and more exciting if the patients are protected and patients return happily at the age of 100 years. Thank you so much.
Thank you. So I request Dr. Suresh Agrath for your concluding remarks and vote of thanks. Dr. Suresh.
Thank you, Dr. Sangram sir, for organizing this wonderful and excellent webinar on the occasion of World Hypertension Day. At the outset, I would like to thank our chief guest, Dr. Narsimlu sir, and guest of honor, Dr. P.S. Shankar sir, Muruganathan sir, and Girish Mathur sir. And there was a wonderful presentation by speaker Dr. P.C. Manoria, and well moderated by Dr. Nagaraj Desai sir. And I sincerely thank our panelists, Dr. Kripalani sir and Antani sir. And I also thank all the delegates who joined virtually and made this event very successful. Definitely, there is a long way to go in the hypertension management. Still, we have not yet conquered, but there is definite way for us. New drugs are coming, as highlighted by Dr. P.C. Manoria, with whatever drugs which are available, and definitely we have to beat our diabetologist and endocrinologist, as repeatedly highlighted by Kripalani sir. Definitely, physicians are waiting in the wing to conquer the hypertension. Thank you very much. Thank you very much, everyone. On behalf of API Karnataka.
Thank you, sir. Thank you. We'll sign out. Thank you. Thank you, one and all. Good night. Good night.
Good night. Thank you.
Bye.
Good night. Good night.
Good night, sir.
Good night.